Thank you, Holly. Again, just echoing, it's wonderful to have everybody here with us this morning. We are thrilled to bring you this presentation today, and I'm honored to introduce our two speakers. So we have Dr. Abigail Angkaw, a consultant with the PTSD consultation program through the National Center for PTSD, clinical psychologist, Deputy Associate Chief of Staff for Outpatient Mental Health at the San Diego VA, and an associate clinical professor at the University of California, San Diego. Her primary research interests include PTSD and co-occurring conditions, as well as improving the delivery of mental health treatment. Dr. Angkaw is personally invested in helping providers through complex clinical and administrative challenges to provide high-quality care for individuals with PTSD. She received her PhD from the University of Cincinnati and completed her internship and postdoctoral fellowship at UCSD and VA San Diego. Dr. Brittany Hall-Clark is a consultant with the National Center for PTSD consultation program and for the Strong Start Training Initiative, where she provides guidance on the implementation of evidence-based PTSD treatment. She is a Texas licensed clinical psychologist and an associate professor within the Division of Behavioral Medicine and the Department of Psychiatry at the University of Texas Health Science Center at San Antonio. For 8 years, she worked at the Fort Hood site of StrongStar as a cognitive behavioral research therapist for several randomized clinical trials focused on PTSD and related conditions in active duty military personnel and veterans. In addition, she practices privately at Insight Psychology and Behavioral Health Services in Pflugerville, Texas. So without further ado, I'm going to turn it over to our speakers.
Thank you so much for having us, and many thanks to ISTSS for inviting us to speak today, and especially to Holly and Melissa for helping to organize. We're very excited to be here and presenting on this topic that seemed important 3 years ago and still seems important today. So my name is Abigail Angkaw. I'm a clinical psychologist and consultant with a PTSD consultation program. And through our PTSD consultation program work, we developed this lecture. We'll be talking about how to treat PTSD when clinicians have strong reactions to patients sharing their sociocultural views. Today, we will not be focused on any sort of specific directionality of patient sociocultural views, like liberal versus conservative or anything like that, but instead we really hope to validate if you or your colleague have strong reactions to patients' thoughts, and that especially if they may or may not conflict with your own, and if you feel challenged or burned out, and give some really practical steps on how to move forward and how to practice. We wanted to acknowledge that we're both here in the United States, and we do hope that what we present today is generalizable to an international audience here at ISTSS. I'm honored to share today's lecture with my colleague, Brittany. Brittany, would you like to introduce yourself?
Good morning, everyone, or whatever time it is in the part of the world you are in. I'm also happy to be here and excited to do this discussion with you all. So we look forward to your thoughts and questions and the discussion at the end.
All right, we'll start with a disclaimer that the views that we're presenting today represent our own and not the institutes that we work with, so not the National Center for PTSD, PTSD Consultation Program, Department of Veteran Affairs, or U.S. government. We have some goals for today, so some of our objectives. We hope to help people to develop strategies that they can utilize if they're having strong reactions to patients' sociocultural views. We'll use examples for psychotherapy, but hopefully this would be applicable to any mental health professional working with patients with PTSD or clients with PTSD. We'll be talking about formulating a conceptualization of patients' views as within or outside of a trauma framework as a means for engendering empathy and focusing on a treatment plan. And then we'll talk about how to use that case conceptualization to determine when and how to address PTSD, or when and how to address a patient's views within PTSD evidence-based treatment. So just to put some framework, we mentioned that Brittany and I both work with a PTSD consultation program through the VA's National Center for PTSD, and we originally developed this lecture 3 years ago. in the context of actually, I think it was 2021 in the context of after the election, and we were here in the United States, and we were having clinicians reach out to us, kind of noticing having more difficulty within their treatment settings. And one thing we acknowledge is that the COVID-19 pandemic beginning 3 years ago began and amplified many shared overlapping personal, social, medical, political, and economic crises. And I'd like to start by considering events that have happened over the past 3 years, and in particular, how passionate and at times how divisive people's reactions have been. And uniquely, mental health clinicians have experienced these large-scale events or crises alongside our clients. So the one thing that we note, and that was initially researched by the American Psychological Association during the first year of the pandemic in 2022 and continued through 2021, is that mental health professionals, specifically psychologists, were reporting having more patient referrals. They were noticing not only having more patient referrals, but also less no-shows, less cancellations, so more people in session. Most people were now providing care via telehealth, and of the folks that they polled, most found that to be more difficult than providing care in person. And 41% reported feeling burned out. And using this definition of being burned out, so physical, emotional, mental exhaustion, accompanied by decreased motivation, lowered performance, and negative attitudes towards oneself and others. And given our audience, I wanted to highlight this part of the definition from the APA Dictionary of Psychology, that burnout can be particularly acute in therapists or counselors doing trauma work, which is likely applicable to everyone here today. And this is just a banner image from this survey that worsening mental health crisis is putting pressures on the psychologist workforce, which I also think would be applicable to social workers, psychiatrists, our licensed mental health practitioners, and everyone. So one thing that this phrase, you may be familiar with this phrase, the personal is political. And when we're talking about this phrase, it refers to this idea, this theory that personal problems are in turn political problems and social, and by extension, social and cultural problems. In other words, the personal problems that we expect and that we want our patients to share in mental health treatment may be the results of sociocultural events that are happening in real time, and that you may also be experiencing. And we should expect our patients to share these sociocultural views and beliefs in mental health treatment right now, especially with so many recent and overlapping stressors that are evoking strong emotions and potentially divisive experiences. And I have this kind of moment that asking folks to kind of just consider and take a moment for yourself and to think about how has your own clinical practice been impacted over the past 3 years since the pandemic began. How have your patients' views about sociocultural events entered into your work? So how have you noticed it, and in what ways have you been addressing this? So moving towards this idea that we do expect our patients to share their sociocultural views in mental health treatment. And I won't go through this list. There's a very, very wide range of sociocultural topics. And this really can be in some ways exacerbated by the means by which people receive their news now. You know, the Pew report found that over 50% of US adults noted that they were receiving their news through social media, through Facebook, through TikTok, through Instagram, which is very readily available in the kind of the deluge of information and communications is at a different level than it was a few years ago or several years ago. And we would expect that people who are coming into session perhaps might have something pop up on their phone while they're in the waiting room, or they might have just seen something that might be on their mind when they come into session. When we're talking with clinicians in our work through the consultation program, we heard about a lot of strong reactions, whether or not people agree or disagree. But depending on what people share, particularly if they're sharing thoughts that maybe a clinician finds to be disparaging or offensive, clinicians shared feeling potentially angry, offended, or disappointed in their patients, having negative reactions. Depending on their theoretical orientation, they might be trying to hide that emotion and have a fear of showing how they are expressing or disclosing anything about how they're feeling. This might lead to them feeling distracted, potentially having some cognitive dissonance, especially if they really have this kind of unconditional positive regard for their patient and now have been presented with something that is in conflict with that. Also, based on the time and this idea of burnout, some clinicians just also shared feeling used to it, detached, kind of dismissing it, minimizing the impact that it might be having on them. And this brings us to kind of the core of the elephant in the room and what we're talking about when we are hoping to focus on in this presentation. The elephant in the room is not necessarily the patient's views or even that initial reaction, but instead that therapeutic impact of the clinician's reaction. So if we think of an elephant in the room as a major problem or a major issue that we might be avoiding or not sure how to kind of not sure how to address, then that this is what we're hoping to focus on, is to give people some concrete information on how to address that. So some examples would be potentially having secondary reactions, so self-doubt or guilt, wondering about their skill set because of how they're feeling, wondering what they should do in terms, especially if they get a direct question from a client, like, who did you vote for? Or what do you think about this policy? Wondering if they should share or should they disclose? If a clinician finds that they're offended or angered by something a client has shared, kind of both ethically and theoretically wondering how do I and can I continue to work and help this client with their PTSD? Definitely a lot of confusion. This is why people consult, and especially confusion about a PTSD treatment plan. And is this to what extent is this related, if at all, and how do I move forward with PTSD treatment? And this is where I'll transition over to Brittany in terms of talking about that first step of addressing those clinician-specific reactions.
Okay. Thank you for that introduction. So as we go on and think about how to proceed, many times people can feel that they're in an ethical dilemma, wondering, should I say anything at all? Or is this more of a personal issue? And depending on theoretical orientation, we might have been socialized in different ways. So some of our identities might be visible. Many of our identities are invisible. So there can be some decision-making around whether the clinician decides to disclose about beliefs or identities that might be different from the client's if it's showing up in the room. There also may be times where clients have come to us for a distinct issue, and we're talking here in the case about recovering from trauma or PTSD, and mental health professionals may wonder, is it relevant for me to bring up these issues? Is it connected to the presenting issue and why the person came to see me for treatment? And then depending on the extent of the challenge or the sociocultural reaction that the therapist is having, the provider may wonder, am I the right person to treat this person, or is it more ethical for me to refer? So there are different points considering whether we should or should not disclose personally. There are some theoretical orientations that encourage social justice advocacy. Some examples could be a feminist or multicultural or relational cultural point of view. We've also seen increasing guidance from professional organizations, such as the American Psychological Association, as well as the American Psychiatric Association and National Association of Social Workers, to encourage respect among clinicians in the therapeutic relationship and within institutions that we exist in. And some scholars have noted that if clinicians do not address remarks that are made by clients that could be insensitive, we could inadvertently collude with oppression. On the other hand, therapists may be concerned about imposing their own values. As was noted in a question, we want to make sure that we are being respectful and considering our own biases and having this decision be thoughtful. There also may be concern about damaging rapport or being perceived as judgmental or overly sensitive. And again, thinking about, is this relevant to the treatment? Is this within my scope as a mental health provider? So there are some different guidances that are available in the literature. When I first did this presentation with Dr. Angkaw, there were 2 models I was familiar with. And now 3 years later, I've become of 7. So here I've consolidated many of the themes to have food for thought and consideration. So one of the first guidelines is to be validating. And this can be challenging, especially if it's a reaction that we are struggling with to maintain our composure. But trying to understand the client's perspective and point of view, and keeping in mind respect. And that can be in terms of our language, taking time to frame the question, making sure that we're using neutral language. And sometimes in the role of a mental health provider, we can feel a pressure to be an expert or think I should know how to handle this. But sometimes when it comes to sociocultural differences, there isn't really one right answer. And it's okay for us to not know and practice, embrace that not knowing. And that can be part of being culturally humble or culturally responsive. Another strategy can be to ask permission from the client to share a reaction of saying, no, I just want to check in with you. And I had a reaction to something that you said. Would it be okay if I shared that with you? And many times clients are also invested in the therapeutic relationship and wanting to preserve rapport and will be willing to hear a provider's perspective. Another aspect of this work can be accepting appropriate expressions of emotion, particularly anger, understanding that many times the images that we see on the media can bring up strong emotions, and there can be fear or frustration about violence that's occurring or inequality, injustice, and things like this. So making sure that we're making space to express that emotion in appropriate, helpful ways. Another strategy can be to consider what's underneath the sociocultural statement and the underlying emotion. Identifying on the surface, it might feel disparaging, but understanding that it might be coming from a place of fear, especially as we think about the conceptualization of PTSD, concern for safety, difficulty trusting others, and being able to connect to the patient's goals of being able to be more comfortable, perhaps connecting with loved ones or being more able to engage in life more fully. Another strategy can be to appeal to values of respect, which might be important for certain sociocultural groups or the military, or values of being open-minded and notice. So I know that you're a person that really appreciates respect. So I wonder if we can carry that forward when we're talking about other people. Another strategy can be to educate and to provide information. Sometimes people have different levels of exposure to knowledge. So sharing alternate information and providing some psychoeducation can be beneficial. Another strategy can be not to take it upon ourselves to try to fix sociocultural issues that are massive in scope in the context of a therapy session, and more to think about mindfully observing rather than trying to fix an issue. I'm trying to get the slide to advance. For some reason, it's not working at the moment. All right, I'm going to try to, okay, sorry about that. Seems like my computer froze. I'm trying to get back into the presentation area.
Brittany, I think it froze on my end and I'm the one sharing, which is, I'm sorry about that.
Okay.
It was while you were presenting.
Got it, no problem. So I'm still trying to go back. Are you able to, do you have control right now? Okay, I gave up control to see if that would help. Or I wonder if I should share on my side if Abigail's froze. So I'll go ahead and pull up the presentation unless I hear otherwise. Sorry about this, everyone.
That sounds great. Thank you for doing that.
Okay, so I'm now sharing my screen. Oh, sorry about that. Okay, so we, as a refresher, we're going over different strategies of how to have these
Brittany?
courageous conversations.
Hey, Brittany, you're
And-
on presenter view. If you just do the
sorry about
display settings, no problem.
Okay, let's see.
So if you go back and if the presenter view shows up on the presenter view, there's oh, that's it. Perfect.
We're good. Sorry about
Thank
that.
you.
Okay. All right. Thanks, everyone. Okay, so the strategies that we just talked about are things that we can do in the middle of a session or when we're with a client or a patient. There are also different things that we can do as providers between sessions to help ourselves process the emotions that we're having. So one of those processes can be self-reflection, checking in with ourselves to think about our own perspectives and experience and how that could be affecting our reactions. Also, being able to practice and prepare in situations like this, and being able to have something that we've practiced with colleagues or on our own can help us feel more equipped when these situations come up and we're managing strong emotions in a moment. And seeking support from colleagues. That can be one reason why you contact us at the consultation program, or more locally, thinking about supervisors or mentors or fellow staff that you could check in with about. And those can be different forums to explore the pros and cons of considering broaching or confronting the topic with your client to check our perspective and our potential for bias, or tolerating. And sometimes if we try to go on and pretend that nothing has happened, then it could affect us as far as our concentration or being able to really focus. So being able to develop a strategy of how to go forward. So Sue et al. Have developed different strategies that can be beneficial, particularly for addressing microaggressions or comments that could be made that are subtle insults that can leave people feeling offended. So these are strategies that can be used by people that are the targets of microaggressions, but also can be for allies and people that are bystanders that are observing a situation like this happening. So this might not only be in the therapy room, but also the waiting room or with office staff, and thinking about a broader perspective. So one strategy is to make the invisible visible and bring attention to it. Sometimes when things like this happen, the discussion is behind closed doors and it doesn't have the ability to affect a change going forward. Another strategy is to disarm the microaggression. And this can be to point out that it might not be a full picture, or it could potentially be a stereotype. And this ties into the third strategy of providing education to the person that has committed a microaggression. And again, you'll see the theme of seeking support and validation when it comes to addressing microaggressions. We also talked about how another ethical decision can be deciding whether we're the right person or right fit for the provider, for the client or patient. This could also be dependent on the therapeutic timing. So if this is right at the beginning of a referral, then that might be a time to consider referring to another person. But if this is in the midst of evidence-based protocol and there's still more work to be done, it might not be feasible to transfer at that particular moment. So looking for different strategies. So if we are in a situation where treating seems to be indicated, the clinician's able to manage the sociocultural reactions to the sociocultural differences There might be limited alternatives like we were talking about, in addition to the timing, thinking about the setting, whether there are high caseloads and not a lot of ability to transfer, or in rural environments where the choices may be more limited. One strategy is to think about ways to incorporate these ideas into the treatment plan. And if it's not directly connected to the presenting issue, there's also ways to do that outside of the treatment plan. On the other hand, if this is a hot spot for the clinician and it's hard to maintain neutrality, then it could be more ethical to refer. Or if there's been an effort to address behavior with the client or the patient and behavior isn't changing, that might be another time to refer. And also in the consideration of group therapy, if it's affecting other group members and the therapeutic goals of the group are being challenged, then that may be a time to consider switching modalities as well. As we've been noting, another aspect of this is self-care, because this can be being a mental health professional can be tiring and have a high toll. And especially during moments like this, it's important to take time to check in with ourselves, think about our work-life balance if we find ourselves taking work home or checking emails at home, making sure that we're having time to recuperate. And again, considering seeking social support, whether it's locally or professional consultation. So I'll turn it back over to Abby.
All right, and I think I'm back. Can you hear me okay?
Yes, you sound good.
All right, I popped out and came right back in. So our next, in this next phase, so what Dr. Hall-Clark was reviewing were kind of some of those immediate actions that we can take as clinicians in terms of considering disclosures and also self-care and potential, even potentially referrals. We'll be moving now more focused on PTSD. So here, we'll be talking about both assessment and also conceptualization as a means for kind of both engendering empathy and also determining a treatment plan. When we're talking about assessment, there are 3 types of assessment, and we're talking specifically about assessment of the, Brittany, I think we're still seeing your screen. There we go. Both assessment of the client's beliefs on the clinician. So what is not necessarily the beliefs, but what is that impact? What is the impact of the reaction? What is the impact on them? Is it impacting their empathy, their ability to communicate, their ability to provide their clinical practice to fidelity? There's a question in that we have about clinicians maybe sharing their own socio-political views with the patient. And, if clinicians find themselves doing that, that could be a potential impact that would be happening, and that may not align with providing patient care in the way that they really would hope to. Also, the impact of the client's beliefs on their own mental health. So depending on what they're sharing, maybe they're sharing something about policies or something they've seen in the news. Are we finding that this is exacerbating their PTSD symptoms? Are they now more hypervigilant? Have they changed their behaviors? Are there more intrusions? Are they now avoiding more or differently than they were based on some of the information that they're sharing about current events? Are there other mental health impacts that they might be having? Are you also noticing change talk related to the beliefs? So are they saying, I think this and I'm arguing with my partner about it, or, other people are upset with me and I'm not sure what to do. And then also the impact of the beliefs on the mental health treatment plan. So are things coming up in session that are impacting treatment engagement? Let's say you're trying to do cognitive processing therapy, and you're finding yourself kind of needing to pull to do the exercises because they're wanting to talk about something else. And then in a group setting, as Dr. Hall-Clark mentioned, is there an impact on a group dynamics and processes that we need to consider? So kind of assessing in a wide range here. Also thinking, could you move to the next slide, please? Trying to see if I can get control here. Here we go. The means for case conceptualization or case formulation, I'm using those phrases it pretty interchangeably here, but this idea of moving beyond a diagnosis, that not just the symptoms of PTSD or major depressive disorder or substance use disorder, but really can we consider all aspects of an individual client's presentation and experience to help organize and hypothesize, but using kind of a theoretical orientation as a background to understand kind of their mental health presentation and also what may be helpful moving forward. I'll be using a case formulation model that's pretty simple. I thought this one might be a nice one if folks aren't familiar, but just know that there are lots and lots of different case formulation, case conceptualization models, definitely kind of firm CBT models, depending on your orientation. And we have a recommended resource here. Dr. Gail Iwamasa has a course on using a culturally responsive case formulation model. The American Psychological Association has one. So we'll be using this 5-piece case formulation model, and I'll use a patient example moving forward to kind of share how to walk through this. So the patient example, it's somebody that we'll call Mr. Arnold. This is definitely not the patient's true name, and we've changed quite a few identifiable information and health information here to preserve confidentiality. But we'll use a patient example to walk us through some of our clinical recommendations. So Mr. Arnold in July 2020 presented to a primary care clinic with needing a referral to mental health, some demographic information. He's a 70-year-old white heterosexual cisgender man. And in the referring narrative, the primary care physician noted that Mr. Arnold's narrative is peppered with inappropriate, racist, homophobic, misogynistic, and anti-Semitic comments. He only wants to see a white male provider. And based on the resources at this institution's site, there was not a white male provider that Mr. Arnold could see. And so he was seen by a white female clinician, a social worker, for an intake. And the presenting problem that was noted at that point in communicating with the clinician is that Mr. Arnold shared that his life has not gone the way he planned. I feel like I'm the victim of ethnic cleansing. Since COVID has started, he's had unstable home housing. He's triggered by Black Lives Matters protests, and that he walks around at night with his gun, hoping that an N-word will start something with him. And so he also was upset about who he was working with. So none of your therapists are white men. We're the largest group that serves the military, and you don't have anyone there for me. And then continue to make racist, homophobic, and sexist comments. And the diagnoses were PTSD and major depressive disorder. He is someone who had multiple childhood trauma since childhood, and more recently, an index trauma of an assault by 3 Black men while unhoused. And so the elephant in the room at this point was the clinician he was working with, feeling kind of anger, offended by some of the comments being made, a bit apprehensive, and also really wondering, how best can they work with Mr. Arnold. And so we'll be using that 5 Ps model as an example of how to move forward and how to potentially conceptualize Mr. Arnold. So the first, here are the 5 Ps here. The presentation is what I just presented, the way that he's kind of presenting a bit aggressively. The language that he's using is notable with the people that the clinicians that he's working with. He also has PTSD symptoms, flashbacks, nightmares. He's isolated and lonely. He's has some fear and vulnerability because of his age and also being unhoused, and kind of a perpetual thought of things being unfair. Predisposing factors are those factors that kind of culturally and from childhood might be impacting his presentation. And so he reported child abuse by a misogynistic father, and that was the phrase that he used. He identified his cultural identity as being a white minority in a racially charged environment through childhood in terms of the place that he grew up. he felt that he's in the military and he felt that his discharge was unfair. He was very close to meeting 20 years in terms of being able to retire and was not able to do so. He has chronically experienced homelessness and has been ineligible for some resources that are targeted towards specific populations, women and ethnic minorities. He also is lacking support and is an older adult and has a disability. The precipitating factors are those more immediate factors that are leading to his current presentation. So I mentioned that index trauma, and using a CBT case formulation, which is the type of orientation that this clinician used, kind of understanding kind of some of those core beliefs, or those he do CPT potential stuck points, but thoughts that Black people will hurt me, I should have known that they would hurt me and run away, that leads to his own feelings of fear, anger, vulnerability, guilt, sadness, and leading to kind of avoidance and aggression towards others, and this kind of being a common CBT cycle. He's also experiencing some perpetuating factors. These are current factors that might be exacerbating what he's experiencing. So the pandemic, racial injustice protest, and he's at the VA and also having reminders of the military, but also he reported protective factors. He has adult children, and he did find therapy actually to be helpful back in 2000, working with a Black female therapist. And so this was actually a change in his thoughts and language noted by the clinician. So this is just an example, and kind of working through a case formulation might be a way to better understand somebody and to potentially build empathy, understand kind of to what extent what they're bringing into the room might be related to PTSD. Don't want to assume that any sociocultural view is going to be related at all to mental health, but using a case formulation would be a way to determine if it is. And then this would move into, what do you do with that case formulation? What do you do with a PTSD treatment plan? And I'll transition over to Brittany. Oh, Brittany, you're muted.
There are some strategies that we can consider that are applicable across theoretical approaches. And many times we are doing evidence-based psychotherapies in this context of treating PTSD. So we're also thinking about striking that balance of addressing an important issue for the sake of therapeutic rapport, but also staying on protocol. And as Dr. Angkaw talked about, if we do decide that the issues are indicated clinically to integrate into treatment, specific strategies for how to do so. So trans-theoretically, we can make space to be culturally sensitive, understanding more about the origin of the thoughts and beliefs. So for instance, in the context of Mr. Arnold, thinking about his childhood and the upbringing of feeling isolated, feeling misunderstood, and how that could be perpetuated throughout his life with the different perpetuating factors that we talked about. There's also an idea of considering our socialization or the cultural templates we might have. We learned from the case history that Mr. Arnold's father, he described as misogynistic. So he grew up in an environment where women were disparaged, and that was what he was used to. And so it makes sense that that can inform his thought processes. So taking a strategy like this can help us to build empathy, understand the client's perspective. In this case with Mr. Arnold, another strategy that the therapist used was to set limits on therapy interfering behavior. One part of the history of the case was there are other providers that had expressed discomfort in working with Mr. Arnold. So having discussions about how the language could be harmful to the relationships he has with providers, or in the context of group therapy, could be impairing the ability for the group to be effective. And many times policies or institutions have a goal of respect for the clinical care environment. And part of that is having respectful language. And if the client statements can be connected to trauma and PTSD, we can tie it into the evidence-based psychotherapy plan. If the statements are not directly connected, there can be education provided through follow-up resources, giving different websites or books or podcasts for consideration. So with Mr. Arnold, in the clinical setting in which he operated, that he was treated, there was a disruptive behavior committee that had an orientation, that had a patient code of conduct, and Mr. Arnold was oriented to this with the emphasis on respecting others, even if we have differences from them. And the provider empathically notified him that his language was an important part of his work in the clinic. And if he was using offensive language, that was not welcomed in the clinic and could interfere with treatment. So Mr. Arnold responded to this limit setting and redirection, and in turn began to limit his comments related to race, gender, and sexual orientation. And the provider expressed a lot of gratitude and praised the client for not using disparaging speech. And the client noted, well, you asked me not to do it. So really honoring the therapeutic relationship. In this process, it was important to provide a lot of support to the provider as she was navigating, do I say something? Is this about me? Is this important for me to address? And she received support that, yes, it was important for the sake of Mr. Arnold, their therapeutic relationship, and the clinic environment. And again, the goal of continuing to build empathy through the case formulation. So when considering how to stay on track and on protocol when we have short-term evidence-based treatment, it can be helpful to remind clients that we have a time-limited approach. So often evidence-based psychotherapies operate between 10 and 15 sessions. So having a discussion of, I can see that this issue is bothering you, and we also have a lot to accomplish today. We have 6 weeks left in our treatment. How do you think we should proceed? And many times after having a discussion and acknowledgement of the client's reaction and feeling, they're ready to continue with the protocol. But if they are really upset, taking a session to talk about it and then getting back on track the next time can also be beneficial. So for Mr. Arnold, some of the strategies that can be considered of how to incorporate information into his treatment plan with psychoeducation. So validating his emotional reaction, that it made sense that he was having an emotional reaction to Black Lives Matter protest because of his index event and the perpetrator and associating them. So starting with the validation, while at the same time having the goal of right-sizing thoughts so that he could have better relationships with people in the clinic, better relationships in his personal life, and working to right-size the thoughts and prevent overgeneralization. In the process of cognitive reappraisal, taking care to do it in a culturally sensitive manner. So thinking about the rationale of why it's important to address the trauma-related thoughts so that he can find a place for them and be able to move forward and not be so consumed and stuck. Being able to word or phrase target cognitions, keeping the issue on the client as opposed to debating the sociocultural issue. So not getting into a debate of what is right when it comes to politics, or for instance, but more coming back to the client's perspective or perceived lack of safety and being able to help the client think about ways to be safe or attend to times that he is safe. Keeping the focus on the client's emotional reaction is part of that process as well. And looking for ways to connect the sociocultural beliefs to the impact of the trauma on the client as well as day-to-day life. So some examples for addressing cognitions in some cognitive restructuring techniques such as cognitive processing therapy. One of the main goals is to focus on trauma-related beliefs first. So for Mr. Arnold, he had the belief, I should have known that they would hurt me and run away. So helping him consider the role of context or the role that hindsight bias might play. After addressing beliefs about why the trauma happened, trauma-related beliefs, we often then shift to related beliefs that overgeneralize to other people. For a treatment like CPT, we're often thinking about specific areas like safety, trust, esteem, power, control, intimacy. So for Mr. Arnold in particular, to help with stuck points around safety or beliefs that he's not safe, helping him to attend to the times that he's been safe around people that are different from him, racially or ethnically. and also helping him understand that risk can be independent of cultural attributes, that there are people that commit crimes regardless of race or ethnicity, and there are also benevolent people that are kind and can be helpful of different races and ethnicities. Another intervention that is used in cognitive processing therapy is a trust star, which is a strategy of helping people think about different types of trust rather than just thinking, yes, I can trust, no, I can't trust. Thinking about, can I trust somebody to drive my car or with a secret or to be on time when we make an appointment? And so thinking about doing trust stars with different people in his life, particularly of people of different backgrounds. And in this particular case, he had a strong therapeutic relationship with a Black female therapist before. So helping him attend to that and apply it to the current therapeutic relationship as well. Another aspect of the sociocultural beliefs addressed with Mr. Arnold could be in the area of esteem. So both for himself as well as other people, and using interventions that are often part of CPT, such as giving and receiving compliments, but with attention to including people that he might normally omit or not attend to. So for instance, in the clinic that he comes to, giving a compliment to office staff, or anyone different from asking him if there's anyone different from him that he respects, whether they're friends or past coworkers. And there are also different strategies exposure-wise or through behavior that we can attend to. So in vivo or in real life exposure, encouraging him to interact with culturally different people in safe places. So helping him do daily things that he might struggle with, such as going to the grocery store or a store where he engages in a hobby that he likes, like fishing. He might ask people of different races or ethnicities for help in a store, cashiers, or in the VA clinic that he was in, or encouraging him to connect from different people in the past from different backgrounds, military or personal, and encouraging him to cordially interact with different staff members. So another aspect of doing PTSD work is processing the trauma. And again, coming back to the idea of understanding where these beliefs started. Did they arise in childhood or earlier in life, or did they stem from the trauma and were they reinforced by the trauma? Again, considering the role of cultural scripts for him in particular with his upbringing, and considering even if this belief feels true, is it helpful? Is it serving you in your relationships with other people? And validating his desire to connect with culturally similar others, which makes sense, that he wanted to have white males that he could connect to, but that's not mutually exclusive with also connecting with others that are different. So wrapping up today, we have talked about a lot. So here are some key take homes. So we know that clients will share their beliefs related to sociocultural concerns in treatment, and that's part of the process. And so it helps us to be prepared and equipped as clinicians to respond appropriately and professionally, checking our own biases along the way and being able to manage any strong reactions that can come up. We can also consider our ethical considerations when we're deciding, are we the right person to treat this client? We also talked about different strategies of case formulation to build empathy and help with decisions related to PTSD treatment. And we did that in both a trans-theoretical way as well as specific evidence-based psychotherapies. And another important theme was seeking self-care and consultation. So we're wrapping up and we'll make some space for questions. We wanted to highlight our consultation program. We encourage you to reach out if you're treating veterans in the community. And we'd be happy to talk about these very issues related to sociocultural challenges or differences, or also more technical questions on protocol. We also have a lecture series that involves cultural themes, and these are some lectures. Dr. Iwamasa talked about cultural case conceptualization. Juliet McClendon talked about being ready to talk about race-based stress and trauma interventions. Dr. Patricia Watson talked about self-care and her stress first aid model, making sure we're tending to ourselves. And I've myself also done a lecture on more specific suggestions on how to address racial stress and trauma in the context of CPT and PE. There are also the APA multicultural guidelines that can be helpful to do a deeper dive into, and a book about voices of color to get perspectives of therapists of color and how to respond to these issues. As part of our National Center for PTSD website, we also have research quarterlies that summarize information that's current in a digestible way, and different websites that can be particularly relevant. And with that, we will end and open it up for questions.
Thank you both for a wonderful talk. I know that we've had a number of questions come in the chat that have been answered kind of as we've been going. We have a couple of outstanding ones really related to the case that was presented. So one person has asked with Mr. Arnold, and he went into this did the changes he made reflect his internal thoughts? And another was the threat to shoot Black people addressed.
Can you repeat that first question? The changes?
Did the changes he made reflect his internal thoughts? And I believe that one came in when, like, on the slide where you were describing that he did shift his behavior following the kind of reorientation to.
You know, that is an interesting question. My exposure to this case specifically was more working with a clinician, so I think the case conceptualization that I best understand, it was more at that initial phase. She did note those behavioral changes, and really I think the apprehension that she felt was that he wouldn't agree if she asked him to, temper some of his changes and behaviors while he was in the clinic. But he just did, he's just like, you asked me to, so I did. I personally don't know enough to see if that reflected a specific change in his thoughts. I can share, and probably similar to, not that dissimilar to other folks' experiences, he was somebody who started cognitive processing therapy. So they were working on a therapy focused on thoughts and did not finish. There was, due to COVID-19 and really sociocultural issues, he lost his housing. That became more pressing and did not finish the treatment. We didn't include that specifically here. Hopefully he's somebody who will come back. And I do think the experience he had, even if brief, was positive in terms of getting started with CPT, working with a therapist, and really being able to have somebody care for him when so many people were pushing him away. There was a second question. So the first was more about the change reflecting his thoughts, and the other one was about his feelings about carrying a gun. I'm sure that they were addressed in terms of they were working closely in our setting. We do have a disruptive behavior committee that will do, and there's definitely an encouragement to do it. Any sort of violence risk assessment, that would be a recommendation anytime somebody brings up or has access to firearms, and that those are more thoughts without any plan or intent.
Thank you for that. I see Naomi has her hand up. I'm going to go ahead and unmute you so you can ask your question. Oh, it might have just been brought down. Okay. Naomi, if you do have a question you want to ask, just raise your hand, and we'll unmute. I'm going to check the Q&A for other questions. In the meantime, I'm wondering, if you have any thoughts or advice on how clinicians can kind of build up these skills to be practiced to use some of these strategies in the moment. I'm thinking about one of my standout elephant in the room moments as something that caught me very flat-footed and unable to reply, and just wondering about in that moment being a slow processor and oh man, I feel like I missed my window. So just if any advice or thoughts you have on how clinicians can kind of preemptively build some of these kinds of skills.
I think there are lots of tools, and if we had more time, I would have gone into more detail with the different 7 models I've been exposed to. But I think one that's pretty user-friendly is called the Racial Healing Handbook by Dr. Annalise Singh. And she tends to focus on race and ethnicity, but I think the strategies can also apply for other types of identities as well. And what I like about it is it's not only helpful education, but it also involves reflective exercises that are experiential as well. And this is something that you can do on your own. personally, or there's also a reading group guide you can do with colleagues, or there's even a version to do with clients. So there are some times that I've shared it with clients and incorporated it into treatment as the client has found helpful. So I think, knowing 10 concrete strategies and practicing them in session, role plays with clients or with colleagues can be helpful ways to do that practice and preparation piece.
I was thinking exactly of the kind of, especially that role of consultation here. Even if you feel like you missed the window, that likely, even though you missed the window, that these sort of experiences and those feelings can stay. And I think if you're able to work in a team-based format and kind of bringing things up, especially when they're active things that have happened, so natural disasters affecting whole communities, maybe it is an election season, people are just bringing things up. I think it's great to talk about it with colleagues, to talk about, what would you say, what did you say, learning from others and kind of how to address it. It does seem like anytime you're learning something, the first times are hard and it becomes kind of a rote, becomes more comfortable. And I think you do get to practice. And I think even with this example of the clinician setting that boundary and limit about the sort of language in the room, first time is hard and it was actually okay. So I imagine that the next time hopefully would be easier.
Thank you so much. I think we have time for one more question. We have one more in the chat. Any recommendations for BIPOC supervisors who are supervising white psychology trainees in incorporating context and culture without centering their own experience? That's the question.
That's a great question.
I'm wondering if the centering is the supervisor or the trainee, but could be both.
Mm-hmm.
But I think that could be in itself a discussion question. And I think the same sort of strategies of asking permission to share a reaction, if, for instance, the supervisor is having a reaction to something that the trainee said, and being mindful of the power differential, but also the goal of professional development. And I think with cultural responsiveness and humility, everyone is always learning. So coming with that collaborative perspective can be a way to have these courageous conversations. Anything you would add, Dr. Angkaw?
No, I would agree. I think noticing kind of that assessment piece and noticing the extent to which we're keeping things client and veteran centered and how much our own thoughts and experiences are really impacting that. But I love that this is framed in terms of a supervisor working with a student. I think using resources and especially consulting and noticing within a team-based framework is something that I would recommend for sure.
Well, thank you both so much again for the presentation today, for your willingness to answer questions. There were lots of thank yous already in the chat, just an outstanding presentation. We feel so grateful that you have spent this hour with us educating us. So thanks again. And thank you to everybody who attended today for joining us. We'll look forward to seeing you next time.
Thank you.
Thanks, everyone.